Dr. Khushboo, Madam is a professor, has been guiding a lot of postgraduate students in the field of gums, implant, and laser dentistry. She has completed her post-graduation from Meenakshi Amal Dental College, Chennai, Tamil Nadu, and she's practicing for more than 10 years over here. And she has lots of publication, national, international journals. So, right now, let's start with the lecture topic here. All the best, guys. The mic is on your court right now. All the best, ma'am.
Thank you so much. Thank you very much for inviting me here as a guest lecturer to People's Dental College, especially the Department of Perio and Dr. Darpan. So, is it visible to everyone? Can I start?
Yes, ma'am.
Okay, so this is one of the most there's a lot of noise from your end. Okay. So, regeneration in periodontics. This is one of the most interesting topics in perio, wherein you get the opportunity to regenerate all the structures of the tooth.
Excuse me.
So, let us see what is. Yes, sir.
You need to share your screen.
Screen is shared.
यहाँ पे हम लोग आपकी स्क्रीन नहीं दिख रही है. You will have a button called share at the bottom of your screen.
1 second. My screen is already sharing. I will stop the share then. I'll do it again. Share screen.
स्क्रीन दिखे तो
Is it visible now?
Not yet, ma'am. ये किसी का कनेक्ट हो गया। हाँ इसका रियलमी चलने दे साइली। Ma'am, we'll share your presentation from this end.
यहाँ से change करा फिर यहाँ से
उनको नहीं लिखा हुआ
हम यहाँ से साइड चेंज कर देते हैं उनको बोलो चेंज से स्लाइड कर देते हैं चेंज कर देंगे
Can you see the screen? with your slides on the screen?
No, my slides are not there. The screen is white. Yeah, now I can see.
I will keep changing the slides from this end. You may please start.
Okay, thank you so much. So, guys, this is regeneration in periodontics, which is supposed to be the most interesting topic in perio. Why? Because we are going to regenerate the lost structures due to disease. Can you change the slide, please? Next, please. Can we change the slide, please? Please go to the second slide. Yeah, thank you. So, coming on to regeneration. All of us would have seen the movie Terminator. What happens in Terminator? That the Terminator dies and he again forms into the full structure all by himself. So this is regeneration, wherein the lost structure can be formed again to its fullest and perfect function. Whereas in repair is something just to manage the lost function. It does not help you in gaining the exact structure and function. Next, please. So let's see what is periodontal regeneration. Now, when due to periodontitis, we have loss of the PDL as well as the bone that occurs, and because of it, we have gingival recession. So in periodontal regeneration, we try to regenerate cementum, PDL fibers as well as bone so that we can keep the gingiva at its perfect position. Next, please. Okay, so there are 4 ways in which the tooth can regenerate or try and heal by itself. Out of them, the first 3 are only repair, wherein it just tries to manage the function, and only 1 is actual regeneration. So when you have the cells of the epithelium that get into the defect, you form a long junctional epithelium wherein no structures are regenerated, it is only a repair. In the second case, when the connective tissue cells get into the defect, they cause tooth resorption and a fibrous connection with the tooth. Again, there is no PDL or bone that is formed. Third, wherein the bone cells get into the defect, they get ankylosed to the tooth. That means there is no PDL structure between the tooth and the bone. So this is called ankylosis. Now obviously, because there is no perfect structure formation here, all these three types are repaired. Perfect regeneration occurs only and only when the PDL cells get into the defect, because the PDL cells will form cementum, PDL as well as the bone, and you have all the three structures back into place with perfect normal function. Next please. So there are two types of regeneration that can occur. One is the whole periodontal attachment regeneration, wherein you have the cementum, PDL and bone. And second, and the just newly confirmed, is the GBR, which is guided bone regeneration, in which you try to regenerate only the bone and no other structures. Next please. So this is the difference between a GBR and a GTR. As you can see here, GBR only focuses on bone formation and nothing else. So it is a sterile environment wherein there is no intrusion from the outside world, and its predictability is much better. Whereas in GTR, because the membrane can come in contact with the gingival sulcus and the outer fluids, its predictability is much less and it is very difficult to maintain its sterile environment. Next please. So everything has pointers to success. So what are the stages in which we can get a successful regeneration here? It depends on the pass percentage. Pass means primary closure, angiogenesis, space creation and stability of the wound. When the wound or when the flaps are in primary closure, it helps in uninterrupted healing and sterile environment of that area. Always blood supply is required for any particular tissue to be alive, so angiogenesis is very important. Space creation is important because only if there is space can we try and regenerate anything there. And stability of the wound is very important because when the blood clot formation is present, can only anything start healing for an uneven full healing to occur. Next please. These are the other factors which depend on the surgeon who is performing the surgery. That is on his selection of membrane, whether it is a resorbable or non-resorbable, whether it is fast resorbing or slow resorbing. Promotion of healing of the primary structures, wherein he has added any soft tissue healing growth factors. Primary closure of the membrane, wherein the membrane should not be moved from here to there after suturing. Stabilization of the membrane to the adjacent bone, which has to be very firm. And sufficient period of healing, because anything requires proper time to heal. You cannot do anything in a non-heal or a non-woven bone. Next please. So why are we talking about GTR? Why do we want to have guided tissue regeneration? So let's say that we've got a patient, you have seen him, he's got calculus and plaque, you've done a thorough scaling and debridement. Now the patient comes back to you, but you take the probing depth and it is still deep. So you think, okay, let's do a periodontal flap. So when you do a normal periodontal flap, you raise your flaps, do the curettage, and you place the flaps back again. So in this case, what happens is that your epithelial cells start in growing very fast and you have a long junctional epithelium that occurs. So again, in this particular situation, you do not have any bone PDL fibers that have been regenerated. So this particular normal flap curettage is only a repair. But when you are using a guided tissue membrane, you place the membrane between your tooth and the defect. Then you place sutures. So what happens is the periodontal ligament fibers get into the defect and they help in formation of periodontal ligament as well as bone. So this is going to help you in forming the perfect periodontal apparatus which was present before periodontitis has occurred. So this is the importance of guided tissue regeneration. Next, please. Now, they are of three types. Ancient, as in earlier people used to use non-resorbable materials for guided tissue regeneration. Later on, we came to know that there are a few difficulties in them and we went on to resorbable ones. Now, resorbable ones also had a difficulty that the predictability was very less. Sometimes the healing occurred faster, sometimes it took a little longer time. So then we thought that with the resorbable membrane, we should have top-ups like we have in ice creams. So let's have top-ups of growth factors or cells which will make the regeneration much faster. Next, please. So coming to the first generation of membranes, which were expanded polytetrafluoroethylene membranes. Now these membranes have two layers. The outer layer has a lot of porosity of bigger holes in them and they are thicker. Whereas the inner layer which is present has small porosities and holes. So what happens, the bigger porosity ones you place towards the tooth surface and the smaller holes you place towards your defect. So when you have big holes, the epithelial cells cannot enter into the region. That is how you hamper your epithelial cells from getting into the defect. Whereas the smaller holes which are present towards your defect, they help the osteoblast cells to get attached to them and make bone formation easier. So here you can see the figure. The outer layer has bigger porosities and the inner layer has smaller porosities. Next, please. Next came the high density PTFE. High density PTFE had very small pore size which was 0.3 microns only and it helped in bone formation much faster. But what we noticed was then when we placed these membranes, sometimes because of a huge defect, the membranes collapsed into the defect. And when your space maintenance is not done, you do not have a defect fill. So they thought that let us reinforce these membranes with titanium. So as you can see in the figure below, an embossed structure, that is the titanium film that is added to the membranes. The advantage of this titanium film is that there is no collapse of the membrane that occurs in the defect and you have a perfect defect fill with bone and PDL. Next, please. Second generation. Now because the first generation membranes were non-resorbable, that means you needed to remove them from the body. So that you have to inflict a second trauma on the patient and remove the membrane. The other disadvantage was that when the bone formed into those porosities of the membrane, it was difficult to remove the membrane. So sometimes we had to remove certain amount of bone and get it out. So what happened? The bone that we actually needed had to be removed in order to remove the membrane. So for that, resorbable membranes were thought for, wherein the membranes resorb by themselves. You do not need to have a second surgical site and you do not need to remove any bone further. They were divided into two types, which is the natural and the artificial. So the natural ones, you can give the best example as an alloderm, which is a human dermis membrane. It has two layers, the outer layer which is smooth and dull and the inner layer which is rough and shiny. Now the smooth layer obviously will be towards the epithelial or the tooth surface because it will hinder the epithelial cells from entering. And the rough surface is going to be towards your defect because it is going to help in bone formation. Now how do you decide this? The first is you can either touch the membrane and see whether it is rough or smooth, or second is called the blood test. So you take a drop of blood, place it on one side of the membrane. If it is going to be the surface which is going to be towards the defect, it will be colored in blood, like you see here, the connective tissue side. And the basement membrane side will not have any coloration of the blood. So the basement membrane goes towards the tooth surface and this connective tissue side goes towards your defect surface. The other very common example is a porcine skin membrane which is called BioGuide. Similarly, again, this has two sides for us to differentiate, a smooth and a rough side. The smooth side goes towards the tooth and the rough side goes towards the defect. The third figure that you can see here is a third generation membrane, but because it is resorbable, I have placed it here. It is called an amniotic membrane. I will talk about it in the later slide. Coming to the synthetic membranes. The most common example is the OsseoQuest, which takes 6 to 14 months for resorption. So you can generally use this membrane in your ridge augmentations. Next, please. Now coming to the third membranes, wherein I had said like an ice cream where we have extra toppings, the third membrane had a lot of extra toppings which could help us in healing. So that was also divided into three. One topping was where you take care of the sterility of the environment where you have done the procedure. So in that you use antibiotics, especially the tetracycline and the amoxicillin, which is embedded in the membrane, and that is a slow release antibiotic which takes care of your infection. The second topping could be sequential resorption of your membrane that occurs. In case if you have a huge defect and you want that defect to fill slowly and perfectly, you put a cylinder kind of a membrane wherein the outer layer is with the hydroxyapatite, the center core is the hydroxyapatite or the polymer, and the inner layer is the polymer. So it takes a little sequence to resorb, and that is how bone forms in sequential way. This is the basis of the 3D scaffolds, which is the most recent periodontal tissue regeneration procedure. The third are the growth factors. So now the amniotic membrane that I talked about, they are the growth factors which are added. It has an epithelial layer, a connective tissue stroma, wherein you have all the cells already in the membrane. So the membrane is placed on the defect and the cells by themselves help in formation. But the advantage with amniotic membrane was that you do not require any suturing. So it is easy for a clinician to just place the membrane on the defect and cover the flaps. Next, please. Now these are various delivery of other growth factors that help us or aid us in faster healing of the defect. They are the amylogenins, the platelet-derived growth factors, the BMPs or the morphogenic factors, and platelet concentrates, which are the most recent ways of periodontal regeneration as of now. Next, please. So these are the amylogenins. That is also called Endogain. It is an US approved way of periodontal healing. It is less invasive, does not require any extra instruments. Just raise a flap, do your curettage and place this sticky kind of a gel into the defect and close the flap. It contains amylogenins which are present from the Hertwig's epithelial root sheet of porcine teeth. All of us would be knowing what's a Hertwig epithelial's root sheet. It helps in starting of our root formation. Next, please. Next, please. So these are the membranes, the various types of membranes that we have spoken about. How do they help us? And what were the advantages and disadvantages? Now coming on to the second most important thing, which is the bone grafting material. Sometimes the defect is so big that the GTR alone cannot manage. I'm having an echo. Okay. So the GTR alone cannot manage the defect. So we have to help in by placing bone grafts. Now bone grafts have three principles. One is osteogenesis, wherein the bone grafts themselves have the cells which have the capacity to form bone. Second is osteoinduction. It's a chemical process wherein the material that is present in the bone graft activates the surrounding live bone to form osteoblasts and then help in forming bone. The third is osteoconduction. It's a physical process. There is no activation of the surrounding bone or anything. You just keep a layer there and then wait for the cells from there to enter into the layer. So it's a physical separation that we have placed. There is something called an osteopromotion also. Osteopromotion is possible only with the emdogain that I said, wherein when you add emdogain to any bone graft material, it helps the bone graft material to form osteoblasts faster. Next, please. Sorry. So there are three types of grafts. As all of us know, autografts, allografts, xenografts, and alloplast. Now, autografts are the grafts that are derived from our own body. Allografts are the grafts that are derived from other person of the same species. Xenograft is a graft that is derived from a completely different species altogether. And alloplast is a synthetic derived graft. There is also something called an isograft. What does an isograft mean? Isograft is when you take a graft from a same monozygotic twin. So in case if you have a twin and you take a graft from the other twin, that is called an isograft. So the examples of the one slide ahead please. Examples, thank you. Examples of the autografts are the osseous coagulum, the bone blend, cancellous bone, and bone swaging. So osseous coagulum is when you harvest only cortical bone from your intraoral sites, which is generally your ramus of the mandible, the symphysis manti, or the ridge that is present in case if the patient has a bulbous ridge. You divide it and cut it into small pieces, mix it with blood, and you have your osseous coagulum. Now what happened, sometimes the particles used to be very fine. So what they thought was, let's make it into a homogeneous good mixture. So all of y'all would have known about an amalgamator for your amalgam fillings. So osseous blend, what they did was they took these particles, put it in a sterile pestle and a mortar, and mixed it like how you mix your amalgam in your amalgamator. So the mixture that was formed was very plastic, uniformly mixed, and it was very malleable and ductile, easier to place in your graft. Next please. Now coming on to the cancellous bone marrow. So what happens is, you use it basically in an edentulous area where you already have some amount of bone. Now we want cancellous bone. So the cortical plate is removed. How do you do it? You raise a flap, especially at the end of your second molar. Use a trephine burr as you can see in the figure here, and place the trephine burr just vertical and let it go inside. So the amount in the second figure that you see, the amount of bone that comes out from the trephine is the cancellous bone. Close the flap, and this cancellous bone is required. You can use it for your filling the defect. The final one is bone swaging. Now here what you can see is that the first picture, you have a defect here near the molar. So you take a chisel or a trephine burr, make a hole just adjacent to the molar, and then with the help of the chisel, once you enter the cancellous bone, dislodge your cancellous bone. The cancellous bone is very soft, it can be dislodged with the help of a chisel. And that is how you place it towards your defect in the molar. The defect that you have formed now is very easily going to be formed into bone, because this is an iatrogenically created defect. It does not have any disease inside. Next please. Now coming to the allografts. They are of two types: freeze-dried bone allograft and demineralized freeze-dried bone allograft. So FDBA is osteoconductive. Osteoconductive means it just forms a physical scaffold. It does not have any activity wherein it is going to stimulate the other bones. How do you harvest it? It is harvested from a human cortical bone at least 12 hours, within the 12 hours of the death. The bone that is harvested is treated with strong acids so that any viral infections or anything that is present is deactivated. Then the bone is defatted, cut into pieces by any instrument, washed with absolute alcohol to make it sterilized, and then it is deep frozen. After that, the particle size is ground and sieved. All of us would have seen what's a sieve. It helps us to divide into various particle size. So they are sieved into 250 to 750 micrometers, and then they are again freeze dried. After that, they are put into the bottles and vacuum sterilized. Now, what is the difference in the DFDBA and the FDBA? In this, you do not have any mineral content that is present. Next, please. In DFDBA, what you do is you demineralize that bone with the help of cold and dilute hydrochloric acid. So once the minerals are removed, you only have the components of the bone matrix that is present. All of us know that bone is of inorganic and organic. So the inorganic components are removed, so the organic components only are left. In that organic components, you have got proteins and certain cells. So when you do a demineralization of these ground products, you get something which is very similar to your collagen fibrils, and these particular molecules are known as bone morphogenetic proteins. These proteins help you in forming bone faster. That is why DFDBA is an osteoinductive graft. Because of the presence of these BMPs help the surrounding bone cells to get converted into osteoblasts. Next, please. Now coming on to the xenografts. Xenografts means from different species. So we have used calf bone, meal bone, and porcine bone. So the most common example is going to be an bio-os. That is an anorganic bovine bone, which is again osteoconductive. It is very porous, so it helps the surrounding osteoblast to get into the defect and form bone. When this bio-os is added with a cell binding polypeptide so that these cells can stay together in harmony, is called pepgen 15. So pepgen 15 is a bio-os with a peptide which helps in binding of the cells. Next, please. Now coming to the synthetically derived alloplasts. The most common example is a bioglass. This particle size is around 90 to 170 micrometers. It is formed of sodium and calcium salts, phosphates and silicon dioxide. When these salts come into contact with the tissue fluid, as you can see in the figure below, the second one, when it comes in contact with the tissue fluid, it forms a gel coating of hydroxycarbonate apatite. Now in this gel coating, in the third figure that you can see, the organic ground proteins get attached to it, which are the chondroitin sulfate and the glycosaminoglycans. And in the fourth figure, after these proteins get attached, they attract osteoblasts to form bone. So this is the process or the chemical process in which synthetic grafts help in forming bone. Next, please. Now this is just in general the way how you can divide all these autografts, allografts and xenografts. The basic difference you can say is that in autograft you have a certain limited amount of graft that is available, because you cannot hamper the normal intraoral site from where you are removing the grafts also. So when you need a larger defect that you have to fill, you can obviously go to a allograft or a xenograft. The disadvantage of them are that because they are from another species or a person, you can tend to have antigenicity of these grafts, which is not going to be present in the autograft. Next, please. Now, how do you place these grafts? So first, you raise a flap After raising a flap, you see the defect or the area where you have to graft. Make little holes around that defect, because that is called cortical perforations, from where you can have your angiogenesis and blood supply to the graft. After that comes stabilization of the membrane, which can be done by the screws that are seen here. They are either fixation screws or tack screws. After that, you have the osteoblast, wherein you either place an autogenous graft on the membrane, and then you have the confined space where you put the membrane. Now I'll explain how does this occur. You raise a flap, you curettage everything, you make the areas in a way that you have a lot of blood supply. You place the graft. On the graft, you place the membrane. The membrane is going to hinder the epithelial cells from entering into your graft, and so you can have your PDL and the bone grafts occurring. To secure the membrane in place, if you have a huge defect, you use your tack screws or the screws, and then you place the flap back again. The flaps, try and place them in primary suture. The membranes should not be exposed. Next, please. Now, tissue engineering is something which is the future of our periodontics. Everything we do, everything that we do, the predictability, we cannot say with 100% surety that no, because I have placed this, I have done this, it is 100% going to form bone. Next, please. So here, like it is said, your limitations are in case of extensive defects, in case of the predictability and the unstable volume of the bone that you use, the quality of the bone that you use. DFBBA, FDBA, you never know. Maybe if it is derived from an old individual or a young individual, the quality of that bone is different. Next, please. That is why the future trend that is now being revolutionized is tissue engineering, wherein you use a scaffold, a biological agent, a cell and blood supply, which is everything present in one, and you place it in the defect. So in simple terms, what I would like to say is, when you have raised a flap, you have a scanner which is going to scan your defect. Then there is going to be a milling machine which is going to have all these ingredients in it, and according to your CAD CAM, how you have in your endo, it is going to mill out an exact size of the defect membrane. What you have to do is, you have to just place that membrane in the defect and stabilize it. That's the most futuristic thing that we are going to try and do now. Next, please. The 3D scaffolds, that's okay. Next, please. Coming on to another very important and recent thing, which are the platelet-derived concentrates. These help in healing of the tissue much better. So they are of two types. They are the platelet-rich plasma and the platelet-rich fibrin. Next, please. The figure that you can see here is of a fibrin. This area that is there present in between is a fibrin clot that is present. So when you remove it, you place it in between two slides or gauze pieces and press it, it forms a clot, a fibrin clot. Next, please. Like seen here in the figure, the clot is in between two slides, and when you place it, it becomes a flat fibrin membrane kind of a thing. This is an autogenous membrane. It is taken from your own blood. Next, please. That's okay. Next, please. Now coming on to the various treatments or the treatment of the defects that have been carried out with the help of either membrane or the grafts. These are a few pictures of the patients that have been treated. So here, as you can see, a full thickness flap is raised, degranulation is completely done, and then the defect is filled with a graft. Next, please. Again, pocket flap was raised, graft is placed and then sutures are given. Here you take care that there is complete primary closure and there is no space left in between. Next please. Here we had used bioglass. So this is an alloplast that was used here. Here you can see in the radiograph there is increased radio opacity that has occurred between the molars. Next please. This is an endoperio lesion. Generally it is always said when you have an endoperio lesion, first do the endo treatment because it is much more predictable, carried by the peri treatment. So again you can see the probing depth of flap was raised, grafting was done, and the two radiographs you can see how bone formation has occurred after 3 months. Next please. See how it has increased after the root canal treatment as well as the periodontal treatment. Next please. This is furcation involvement. Again you can have furcation bone loss that occurs. Like here, I had said we have used extra topping here. Extra topping means we have used growth factor along with the bone graft which is going to aid in faster osteogenesis. Next please. This is the radiograph where radio opacity is visible. Next please. Now coming to the GBR, that is the only sole guided bone regeneration. There is a buccal defect. If you can see, there are holes that were created because of increased blood supply. Here we had used a graft, and this is the amniotic membrane that was used. Like we said, you do not need to suture this particular membrane. It directly adheres to the graft, and then sutures were placed. Next please. Socket preservation. Socket preservation, why do you need to graft? Because generally we say that in the process of healing there is at least 1 mm of bone reduction that occurs after extraction. So when you have filled the socket, the resorption of that healing that take place decreases. So here as you can see, we had used PRF as well as the bone graft because the platelet concentrations help in increasing the healing faster. So we had placed the graft. After that, in the second last figure you can see the PRF membrane that is tucked in and the sutures are placed. The PRF membrane that we use also increases in the soft tissue bulk of your tooth of the region. Next please. So this is the radiograph that is visible, extraction and post socket preservation. Next please. Again there is a furcation which we had treated only with GTR because the furcation was just kind of very shallow grade 2 furcation wherein we thought bone grafting is not required. So it was just the membrane that here the membrane that was placed was Healy guide. Membrane is placed, it is sutured, and then the grafts have been placed. In the pre-op radiograph, there is a little black shadow which has completely gone off in the post-operative radiograph that you see after at least 3 months. Next, please. So thank you very much. This was my way of trying to just make a gist of the most important topic in perio, which is very vast. Try to take it in 1 hour as much as possible. The hands-on course would be taken on further by Dr. Sumedha. So Dr. Sumedha, over to you. Thank you so much. Are there any questions or anything that you would want me to answer in case if anyone has?
Any questions, students? किसी को doubt नहीं है?
This is a concise explanation of your Carranza that you would have read in your final year. It's just a kind of a revision for all of y'all, but maybe the cases are something that you would not have seen.
हाँ वो करो थोड़ा सा कंप्लीट I can find it. Any questions, students? Any questions? Thank you, Dr. Khushboo.
Thank you so much. It was my pleasure. Thank you for inviting me. I hope you have fun in the hands-on demonstration.
Thank you so much, ma'am.
Thank you very much. Take care. Bye-bye.